Dr. Raj Tobin is ready with her presentation, and she's a director and head of Department of Anesthesiology at Max Super Specialty Hospital in New Delhi. And her interests are onco-anesthesia and renal transplant. Interests, in addition to regional anesthesia, is patient safety, a very good, important sort of like area to look at it these days. And she's going to talk to us about TAP and quadratus lumborum block.
I'll be touching briefly on paravertebral too. It's always good to be in Goa. Good afternoon, everyone, and thank you, Atul, and thank you, Dr. Agarwal. I think he's not here now. ICPM conferences are like family reunions now, and I did my first ultrasound workshop with Atul, and so I have a huge attachment with this group. I'm going to, as my previous speaker told you, that we are not looking at any nerves when we talk about these blocks. So I'm going to be speaking on TAP, rectus sheath, inguinal block, quadratus lumborum, and I'll just 4 slides of paravertebral because it becomes a truncal block. So I will start with the most basic that is a posterior TAP. So this is anatomy. I don't think I need to go into details. So there are paired muscles, rectus abdominis in the midline, paired muscle, and then external oblique, like the direction we know, like your hand in the pocket, internal oblique in the opposite direction, and transverses as the literal translation is the fibers run almost parallel. And what is most significant about these muscles is this whole lot of this muscle becomes aponeurotic, as they come medially and as they go near the inguinal ligament. So, and of course, the anatomy of arcuate ligament, that when we talk about rectus sheath block, we are kind of staying above the arcuate ligament because there is no posterior rectus sheath below the arcuate ligament. So this is just a brief anatomy and another picture. So these are the areas where we will be kind of targeting them as we go ahead. Let me take you to the other slide. So this is again the anatomy for you to get a picture of how difficult it is to give a block above this because the costal cartilages and the ribs are here. So all of our blocks are focused here. So somewhere here is a rectus sheath block, and somewhere here is where we get the subcostal tap, and here is our original Petit's triangle tap. And of course, for children, we try to block the ilinguinal and iliohypogastric nerve, and quadratus lumborum is, of course, another ballgame altogether. So this is again showing you the same thing, the arrows. So we'll start with posterior tap. Many of the senior anesthetists, I had never given this block till we started giving with ultrasound, but many people have given with the double pop technique, the posterior tap block. So the plane of tap is as we say, the tap plane now. So between the transversus abdominis and internal oblique muscle, we are basically targeting the lateral cutaneous branches. And as we go anteriorly, and when we go focus for the rectus sheath block, we are kind of this is the vertebral body, and as we go anteriorly, we are targeting the anterior cutaneous branches and in the rectus sheath block. So I move forward, and this is the area we kind of cover when we talk about the conventional tap block or the posterior tap. So you can give it for LSCS, and you can give it for, now we are using it for renal transplant patients too. I will tell you why in a while. And this is again a picture to show where we are putting the drug between these two muscle planes. I think most of you know the dangers. Of course, there can be bowel perforation, there can be intraperitoneal, and it can be transient febrile anesthesia. This is how we place the patient. So there's a cranial and the caudal end, as you can see. And the best part about this block is, because the surgery is in that area. So that area is already sterile. So we tell the staff not to disturb the sterility of that area. So kind of once the surgery is over, they clean up, they put a dressing, and so in our hospitals, we still use the same surgical asepsis which the surgeons use. So we kind of wash and drape the patient, and we drape ourselves and wear gloves and gown ourselves, and we use Stimuplex needles, Sonoplex needles for taps. We get 8 to 10 centimeters in our country, very rarely 5 centimeters. So again, linear high frequency probe, and of course, this is a picture from one of the girls who has a fellowship in OBS, so she's kind of giving it from the opposite side. Most of us, we stay on the side that we're giving the block, and we keep the monitor opposite, so it is a little tedious that we turn the machine around, but we always stand on this side and we keep the machine in front. So if I'm giving the block on this side, I stand on this side, and if I'm giving the block on the opposite side, as the picture shows here, I kind of keep them, again, I'm standing facing the machine. I kind of don't take the probe on the other side. So, I stay here, and when I'm giving a block, I stay on that side. So most of us do that. And of course, it is since it's a plain block, so we have to give huge volume. So we give 15 to 20 ml, keeping the volume, the dose in mind. And yes, though it is a plain block, it goes without saying that you still aspirate and give. So you aspirate and kind of, we are not trying to catch a train, so give the drug slowly, and it's very nice to see the space opening up. I think it's very nice. So this is the anatomy. The sono anatomy. So this is the bowel. I normally count from below upwards because sometimes in fat patients, we have a lot of very fat patients in New Delhi. So this becomes very confusing. So we look at the bowel, then transverses. This is usually a slimmer muscle, and the internal oblique in the tap plane is usually the fatter muscle, and it because it is arising from the lateral 2/3 of the inguinal ligament. So a lot of muscle belly here, and of course the external oblique on top. And this is just a very, very brief video, just to show you. So there's a needle coming in from there, and this is the plane that we are targeting. And this is probably a patient after cesarean, so she's kind of breathing, not a patient under IPPV. And this is, she's gone beyond a bit, and the needle goes away from the vision, and we see the space opening up. You can get much better video than this actually. So now we come to the subcostal tap. So we spoke about the posterior tap, and then this is the area that we are targeting in subcostal. Very limited use actually, not much. We may use it once in a while when you have a very sick patient and surgeon wants to put a drain and a very bad gallbladder. They say that, okay, we'll put a pigtail and we'll come back and operate later. So I don't know, in my practice, very few times that we kind of put this block, because any other surgery like a radical chole, even if the surgeon is making a small incision here, this is actually not the ideal block, because we can go and put a paravertebral if we don't want to put an epidural. But yeah, it's a good block in certain cases, and it's good to know about this block, because over here T6 to T9 nerves have a very variable course. And so for effective analgesia, we kind of have to stay very close to the costal cartilage. And I will tell you the reason why. When you look at this anatomy, as I told you, these muscles are as much aponeurotic as is the muscle belly, So as they come medially, they become quite aponeurotic. And you can see, as they come medially, the internal transverse abdominis. A bit of transverse is what stays, you can see the muscle fibers as it moves medially. So when this is from one of the articles. I'm sorry, I think that referral is missing. So this is a costal cartilage. This is the transverse abdominis muscle. This is the rectus abdominis muscle, and this is the tap plane. So tap plane stays the same everywhere. But over here, up, in the, between T6 and T8, you don't know whether the nerves are going to be in the tap plane, or maybe they will kind of run into rectus and run within rectus, or maybe they will climb up and kind of run above the posterior rectus sheath. So the course is very variable here, and so if you want to target with the subcostal block some of these nerves, then you got to stay here where you know that nerves are probably in this plane. So this is just a video to show you. So this big muscle over here is a rectus abdominis muscle. So I'm moving laterally now. This was linea alba here. Okay, so I'm moving this big belly is rectus abdominis muscle, and you will see a muscle slipping underneath rectus now if you keep watching it. And so I think you can see this muscle which is slipped in here. This is the transverse abdominis muscle, and so we just go little laterally, you know, we come near the costal cartilage, and that is where we target it. And as I keep moving laterally, this is just to show you the anatomy. You see, there are no other muscles here because this is all become upper neurotic. And you will see why, because as I move even more laterally, you can see the typical 3 muscles here. So this is the only point of interest in a subcostal tab. Okay, so now I move to the rectus sheath block, yeah, because we do a lot of cancer surgery, so we really like this block, and also in many of the lab procedures, you know, depending on where the port is. The best part about abdominal blocks is that, you know, you can really do a permutation combination. You can combine a rectus with subcostal, you can combine a tap with rectus. So depending on where they're putting, because now they're putting ports everywhere, like they do robotic surgery, I don't know how many ports they put. And you want to give as much comfort to patient as possible, you know. So depending on where they're putting a port, we kind of inject these drugs. So this, of course, the rectus sheath block, as I told you, that this is the area we're targeting. So we you know, when they want to do feeding jejunostomy, in a really bad patient, and you don't want to give cachexic patient, you don't want to give any anesthesia, you definitely don't want to give spinal. And this works absolutely fine. You run a bit of dexmedetomidine and you give this block, and most of the surgeons manage to get this done in about half an hour. So this is the area we are targeting. This is the area we also target, you know, in ventral hernia surgery, and patient wakes up really pain-free. So this is again a video. You know, this is the linea alba, and these are the 2 belly of recti muscle on the either side. And if you run if I run it, so this is the rectus, so, you know. And these are the other muscles coming up. So this is, you know, I've kept this probe somewhere above the umbilical, so that's why you can see these muscles quite well in the midline. And if I run it further, you can see the rest of the, and now I'm going to show you the plane. So this is, of course, anatomy. So this is the anterior rectus sheath, and this is the rectus abdominis muscle, and this is the posterior rectus sheath. So here the drug we deposit is bit above the posterior rectus sheath. So the rectus muscle will kind of move up. So it is very important for you, because there is a potential space there, and that is a space which we are targeting. And if you're in the right plane, you can see the belly of the rectus move up beautifully. So this is just a video to show you. So you can see, and this is a cachexic muscle, so balls are dancing here, and you can see the rectus, and you can see the sheath. You can appreciate, I'm sure most of you can appreciate this sheath very nicely visible here. So you know, you are in the right plane, and you should be able to see. This was another picture, again lifting away of rectus, and you can see the posterior rectus sheath very nicely. Inguinal block, I'm not going to go into details of it. Mostly for pediatric patients, we don't give it in adult patients. I'm sure you all are aware of this anatomy, and you know the reason we're giving it. But yes, we love it in children because our surgeon is really, really good, though it's very difficult to convince him to give this block most of the time. But wherever we give this block, patient comes out of the theater, and in 20 minutes we are feeding them in the PACO. So, and of course we don't use this. This is just to show you the position. So one end kinds of nudges against the anterior superior iliac spine, and the other one is pointing towards the umbilicus. In children, we use a probe which has a small footprint, the hockey stick probe, and it's really, it's again the tap plane that you're, so I don't believe these are the nerves. I think there are articles now also saying that you really don't see the nerves, but this is one of the old pictures when we thought we were seeing the nerves, but it is just a plane. You hit that plane, you give the drug, and you get the effect. Just 4 slides for paravertebral. So this is the block we use really, really a lot in our hospital. We used to do breast patients with paravertebral now earlier, but since PECs came in, we find it so much more convenient. You don't have to turn the patient. Our technicians are really very happy because it's very tedious for them. We anyway give these blocks under general anesthesia in our breast patients. Ours is a private setup, and patients don't like to get poked all over. And now we are giving these paravertebral blocks in all our lung surgery. So all lung surgeries, we rarely ever give an epidural. We always give a paravertebral block unless patient is on dual antiplatelet or there's some other reason. So anatomy, yes. So idea of showing this image is basically we want to stay behind the endothoracic. This is endothoracic fascia. And if you see the nerves, they're behind the endothoracic fascia. The idea is not to go in front of that, because then you may not get an adequate effect. And of course, this is their anatomy, and we all try to stay behind it. It's not always possible, because there are times when the surgeon kind of puts his scope up and says, "वो देखो ma'am, आपका catheter पड़ा हुआ है," because we have gone through the endothoracic patient. So it happens once in a while, but yeah, because of pleural effusion, whatever, you get a good effect. But this, now with sufficient skill, we are managing it pretty well. We put catheter and patients are absolutely fine. We rarely give any narcotic post-op. They do the physio right from the evening of surgery, and this is really a good block. And the other thing I wanted to share with you all is that we do not give it in plane. We always give it out of plane. So this is of course in plane technique, but we give out of plane. This is how, this is just for your, we kind of mark to show you all. So this is of course the spinous process and the transverse processes. This is just another picture from the web. So the reason we give out of plane, I will come to it in a while. So this is just to show you the anatomy. So so your skin, subcutaneous tissue, and erectospinal group of muscles, and external intercostal membrane. And this is the space that we are targeting. These are the transverse processes, costothoracic ligament, pleura, lung. Yes, we use an epidural needle here to put a catheter. Now, the reason I said we give out of plane is, we have been giving out of plane for last 7 years in our hospital. And we always, when we get visiting faculty, they always argue with us, okay, no, we give in plane. So maybe, yeah, I'm sure. But we find it safer because even the junior level guys are giving it. And we have had one case where it became, it became an epidural, with an out of plane. But with in-plane approach, I have heard of people getting an epidural, and now you see, if you look at the anatomy, so this is the spinal cord, the anatomy department of Safdarjung Hospital was kind enough to cut the vertebrae and dissect it for us. And you can see these are the nerves coming out, and somewhere here is a dorsal root ganglia, and this dividing into ventral and dorsal division, and somewhere here is what we are targeting. So there is hardly any space here, So if you give in plane, and suppose this was where the transverse process was, so there's hardly, I don't see how you can ensure every time that your needle kind of, because there's a black space there, and yeah, I'm sure people are doing it. Atul is looking at it very seriously from there, but yeah, but in our setup, because all levels of anesthetists are doing it, we do an out of plane with hydrodissection.
We are admiring your effort to explore it further.
So if your sister is an anatomist, it makes life easy. So this is just this is again a little bit old video, but yeah. So this is the approach we use. Patient is lying supine, on the side, and a patient is under general anesthesia. So we load, we take an epidural needle, and we kind of do a little bit of hydrodissection as we go down. You can see so slow, because you always have apprehension, and you can see the pleura dipping down here. And since we are using an epidural and patient is an IPPV, so we are not so scared of pneumo. But this is how we do it, and this is how we have been doing it for so many years. So now I come to the last block, which is a quadratus lumborum block. As it was covered by an earlier speaker, that lumbar plexus block, we were always very, and I think I had a discussion with Atul in 2013, if I remember, after that Shamrock article came out. So we were all very enthusiastic about it, but somehow we didn't explore that block much. Probably we were still in the, still in the steep part of a learning curve. And now we are giving this lovely article by one Japanese, Ushima. He has kind of explained it very well. So we have QL1 and QL2 and QL3, and I will come to it later. And so this is the anatomy, just to get a, so that you get a 3D image of what a QL block is like. So we have the psoas, and we have the quadratus lumborum muscle, and there's a nerves all coming out between these two muscles. And if you if you see the abdomen, so that is where all your abdominal muscles are there. Now this is how we keep the patient. So this is a natal cleft. So this is the caudal end, that's the cranial end. This is a transplant patient. So this is the anterior superior, rather anterior superior spinal part, a little behind that. And this is anatomy exactly when you put a probe here. So you can see the quadratus lumborum. Then you have the paraspinal muscles. It's a group of muscles. There's longissimus and spinalis and iliacostalis. So I cannot identify between between them. I know they're kind of paraspinal muscles, and then of course erector spinae muscles, and this is the psoas major muscle. So when we talk about the QLs block, earlier the QL block used to be given somewhere here. So this is the fascia transversalis, the red line, and this is the transversus abdominis aponeurosis, and yes, it is absolutely, I think there is a YouTube by somebody from NHS, Dr. Shiv Kumar Singh, I think, and he has used a nerve stimulator to stimulate it, stimulate over here, and he has found the abdominal muscles, contracting, and this is where the QL1 was traditionally being given. We have also given it earlier in some of our patients. And how much ever we tried, we could not give it in our transplant patients, because the surgeons put a bad retractor. It is something like a Book-Walter retractor, which is really, really a bad retractor, but this is equally bad, and you really can't see anything after the transplant is over. And then, then some of them started giving it here, between the QL and paraspinal or ectospinal muscle. They call it a posterior QL block. The only thing which convinces me is that probably the drug trickles here, or maybe the drug trickles back to paravertebral space. I think there's one or two publication about it going to paravertebral space. I have not really read it, but my juniors tell me there are some reports, but not too much work. So, but there Danish guys are kind of giving it here. I think Sutter is his name, and he has been, giving drug between the QL and psoas major muscle. And this sounds a little convincing to me also, because the nerves are coming out from here and kind of we are targeting it much earlier, and probably it is trickling back into the paravertebral space. So you give enough volume. And we are giving this in our kidney transplant patients, and we are really very happy with it, because most of them are not really very obese. We see this area very well. So unless they are on dual antiplatelets, we give this block, and we are very, very happy with the results. So just to take you forward on this, again, our anatomy, to correlate to the sonoanatomy. So this is the transverse process, L4, can be L3 or 4, psoas and QL. So the difference between these two, which is mostly seen very well in most of the patients, QL is, quadratus lumborum is a much darker muscle, and psoas is a much whiter muscle. So this is, you can see these muscles really very well with your machine, especially this edge is absolutely a phenomenal machine. And you have the transverse processes, the depth is little more than required, and rectospinal group of muscles, and you bring your needle from behind, from the back, and you kind of come and hit this plane, and you inject the drug, you aspirate and inject the drug. So this is the block that we are using. So just to show you, not very good images, but because it's a deeper block, so you can see the needle in this, the needle is coming from there. This is the quadratus. If I go forward here, you'll see the abdominal muscles. This is a psoas here, and when you run the video, you can see my drug is, anyway, the drug is already lying there. This is just to show you the needle placement. This is another one, probably in this you can see the space separating. You can see the needle coming in. So we are giving, this is yet another video. Anyway, so this is QL block now, but I will share something else with you too, that after having given QL for last 8 months, we were like very happy that now our renal transplant patients are so pain-free, and kind of, we would hardly give them anything. And then, when you do about 28-30 transplants, sometimes the surgeons ask you very politely that, oh, do you mind, Dr. Raj, if we do a patient with dual antiplatelet? We have been doing it. Most of, the guys from SGPGI, by the way, Dr. Anand Kumar. And, when surgeon talks to you very politely, you are at a loss. Because lad le to lad lo. Lekin politely कहते हैं तो you find yourself saying yes. So, so we agreed. And when we started doing in these patients, they come once in 2 months with the dual antiplatelet. And, there are 3-4 patients lying in the transplant unit. And so others are very comfortable. And this is the guy who's kind of having so much pain. So we felt that we should give them something too. And that is when we went back on the transversus abdomen, the TAP plane block. And so we couldn't see it in the Petit's triangle. So we thought, okay, let's give it wherever we can see it. And then we started giving this taps wherever we could see it, up, little up. And we found that patients are as happy. So, we don't have to turn the patient and go and give a QL block, because they are waking up very well. So then when I saw Shiv Kumar Singh's video, and I thought, yeah, I mean, we are doing a lot of effort. So probably QL block is good if you're kind of really trying to target the upper part of thigh too. But we don't have a study. We're planning to do a study and see whether fentanyl requirement is a little different over there for 24 hours. But yeah, we are finding very good effect even with TAP. Any TAP plane you give it, and patient wakes up pain-free. So these are some of the pearls which I think our previous presenters have already covered, that keep everything in line of sight, be aware of the anatomy, nothing like knowing your anatomy, because if the mind doesn't know, eyes cannot see. And in QL block especially, you must watch out for liver and kidney, because the patient may have an enlarged kidney or an enlarged liver, depending on which side you are. So, of course, for all of these blocks which I mentioned, and which the earlier speaker, we use a linear probe. QL is the only one where we use a curvy linear probe, and of course inject slowly and aspirate. So, not many youngsters get very excited and they just push the drug in. So that one must watch for. And I always tell them, have somebody watching you while you're doing the block. So that is, I think, the best. And of course, always keep the toxic dose in mind. And thank you very much. This is a photograph from a cadaver workshop. I believe a lot in knowing your anatomy. Thank you very much.
Thank you, Dr. Tobin. That was a very nice demonstration of all those videos. I didn't feel as if we have lost out on actual live demonstration here.
Good afternoon, everybody. Thank you so much, Prashant. And thank you all for coming for this conference. I know we are in post-lunch session, and I'll try to do justice to this topic, which I think is not one of the easiest ones. But there you go. Shall we start? Or there's still some more people coming in. Shall we just give another minute or two for everybody to gather in? Or? Right, okay, let's start then. Okay, so the topic given to me was spinal sonoanatomy. As we all know, do we all use ultrasound for this central neoaxial blockade? No, okay. Yes, anybody put your hands up if you do? Right, okay, there's a couple of people, fine, great. Please help me if you're thinking I'm talking something which I shouldn't be, please remind me of the same. So, to start with, why ultrasound is not so popular in this central neoaxial blockade? First thing was that we are so good via the landmark technique that do we really need to explore this? That was the biggest question. So most of the people feel that my success rate is already high with the landmark technique, and so I don't need to use ultrasound. Secondly, bones. We know with ultrasound that ultrasound does not pierce or go through the bones. So most of the time what we see is a hyperechoic shadows. So it's very difficult to pierce through the bone. And hence, we have a very limited acoustic windows. Now, there are a couple of terms I'll be using, acoustic windows and acoustic shadows. Window is between the two bones where you, with ultrasound, will penetrate through and show us something. That will be the window. And the shadow is something like shadow of when the ultrasound will hit the bone, it will cause a shadow. Now, I'll just explain it. It's really important, that's why I'll explain it. So if, say, this is the light I'm shining, so it won't pass through the bone, but if the light is here, that will go through in between the bones, and that will, of course, give us a window. So this is a shadow, and this will be the window. And clearly, as we know, if I were to put the shadow created when the light is hitting the bone, the shadow is far, far much more bigger. So hence the window becomes smaller. So that was also one of the limitations that people are not very fond of, that they can't see in between. And next thing is, if they are obese, adipose tissue, and plus the teaching and training, it has a long, it's not a steep curve. It's quite a flat curve. It takes time to learn this. Why? This is the question, why ultrasound is helpful. So if you have a patient who's got scoliosis or got metal, then it's not so easy. And then we think that, oh, this patient, I tried and I couldn't. Plus, if they're obese, if this kind of patient, for landmark to palpate or to achieve the intercrystal line, Tuffius line, it may not be so easy. However, to give a general anesthetic to these kind of patients is going to be challenging. So if we can get away by doing a regional, it's a bonus. So that's why ultrasound comes into play. So it was first described by Koch in 1980. And they said that ultrasonic localization of space is really easy. Well, they didn't say it's easy, but they said that it can be done. Surprisingly, the next time, it took about 20-odd years, 2 decades, when it still didn't come into very much into light. And then it was first by Grau in 2001, he said that it can be used. By February, he said that there are some lots of technical possibilities and limitations of ultrasound because they were not getting enough windows. However, they were able to do in some population, but not all. But by May, they said, well, if you do rather than any other axis, but if you go paramedian, that's a very good window. And then I think that after that, it just started flying. Then there were some case reports of people going too high, but nobody wants to go too high. Nobody wants to go at T12L1 to do a spinal and epidural, unless there's a risk of dural puncture and all that stuff and causing nervous damage. So Furness published that, okay, fine, can we not identify the level at where we are? So they compared it, did a study. Any rough guesses that while palpatory method, how many times are we successful in doing or identifying correct level? Right, any other guesses? So one of our friends says 50%. Sorry? 10%, that's a bit low. But you're very close, when it was about 30%. So only 3 out of 10 times that we were thinking that, okay, fine, this is L4, L3, or L3, L4. So objectives today, what I'm trying to do is that we're going to identify the sonoanatomy of some important landmarks, which are the spinous process, the lamina, the articular process, and the transverse process. Followed by, to identify the midline, followed by the level, measure the depth at which we think the dural space is going to be, or the posterior dura mater complex for that reason. We'll come to it in a second. Planes, what are the different planes which are used to scanning? The most important planes which are used are parasagittal plane. And say if parasagittal is, we all know where parasagittal is, so I'm not going to go into those, we are all senior people here. And if you tilt the probe, say if this was the back, if this is parasagittal, if you tilt the probe slightly inwards, it becomes parasagittal oblique. Then the transverse or axial plane. So these are the 3 planes which are mainly used for identification of the epidural space. So what are the advantages? One is we can identify the correct interspaces. We can identify the trajectory in which we have to go. Just identifying space, we could think that, okay, fine, I've found the space, this is where it's going to be. But so many times we think, oh, why even landmark technique, we say, oh, just tilt your needle slightly, go upwards or slant it downwards, and somehow you'll be able to get it. But why ultrasound? Now we should be able to see what trajectory we should be using in the first pass. And using all that, it has proven that it leads to less complications of dural puncture because we know the approximate depth at which we have to be there, and also reduces the chances of failure. And with that leads to a better patient stroke maternal satisfaction, and accuracy of insertion of the central neoaxial blockade or epidural catheter gets better. Now you'll argue whether this will cause our block to be faster, or can we perform it in less duration, or is it going to lengthen the duration of the time we're going to spend in the anesthetic room? But if you know where you're going to go, then possibly that will reduce your total anesthetic time. So we'll go to basics first, if I may just touch, because one of the important things is to know where is the spinous process. So we all know this is what a typical lumbar vertebra looks like. So that's the body, that's the spinous process. The 2 bones which join together to form the spinous process is the lamina. Then there are these joints, these things which, so these are articular processes. So these articular processes, so the superior articular process of the inferior vertebra meets up with the inferior articular process of the superior vertebra to form the joint, and that's what is called as facet joint. I'm sure we all know that, but I just touch basics here. And this structure, that's the transverse process. Why I'm saying that, it'll be important when we'll be scanning. So either we start from midline outwards, or we can come from outwards and inwards. And the images which will be generated by the ultrasound, we'll see in a second how it looks. But please remember, transverse process, articular process, laminar, and the spinous process. Please feel free to stop me at any point if you think I'm going too fast. Are we okay so far? So that's the spinous process. This is the interspinous space where we are aiming to go. That's the lamina, and that's the spinous process again. So how does this lumbar vertebra actually looks like? So the first one is a posterior view. This is how it will look like, and you see that the interspace is not too much, and hence this trajectory is important to know. It's worse when you're at the thoracic level, but for the time being, we'll just stay on to the lumbar vertebra. This is how it will look like in the lateral view, and that is the anterior view. So when they all are together, there's some kind of a thing which automatically stands out. Like if you just forget anything from down below here, and if you try to imagine how this structure would look like, would it look like something like a bat? So these could be the eyes, these can be the wings, and that's what typically, if you have read any, I'm sure you all have read papers, that bat wing appearance. That's what those people are trying to describe. But these are these articular processes. Down here is the lamina, and these are the transverse processes. I'm not going to go into too much details of these preparation and things. We know it all, so we'll just move forward. So imaging planes. The first one is paramedian. So that's the median. So just slight lateral to it is paramedian sagittal plane. Next one, if you appreciate the difference in the probe position, now we are just tilted slightly inwards. We are just showing the light slightly inwards towards the cord. And possibly, if you think that this is spinous process, this line, just next to it, with the bone which was joining together to form the spinous process was the lamina. So this probably we are shining the light through the lamina, as Grau described, the paramedian approach. And the next thing, to know where we are and are we within the interspinous space, is the transverse. So these are the three axes which we'll be using to scan. So what are we expected to see? Well, bone, we know that it causes hyperechoic shadow. Connective tissues, they also look like hyperechoic. So if there's some tissues there, they'll look hyperechoic. But how would the fat or any fluid-filled space, how will it look like? That would look like something like this hypoechoic structure. I'll explain all of that in further slides. But if we look at, this is the bone, hyperechoic shadows. There's some more bone there, some more bone there. And these are some more hyperechoic structures. And in between that is this kind of a fat-filled space or fluid-filled space, which is hypoechoic. Now, these ones, again remembering for the bat wing appearance, so these are the articular processes. Further big structures going transverse across, these are the transverse processes. Just next to it here is your posterior dural complex. Just in front of that, just behind the vertebral body, would be your anterior complex. And these structures are your ligaments, which are joining the spinous processes together, your interspinous ligament, your supraspinous ligaments. So if we are scanning somewhere from going from outwards to inwards, if your probe is somewhere out, you're flashing the light somewhere at the transverse process, that's some kind of an image you would expect. We know the muscles, which are the paraspinal muscle, which are somewhere there. Those muscles, well, one of the muscle is erector spinae muscle. In front of that, you get a psoas muscle. So that's the image which is generated. So that's your erector spinae muscle. In between this muscle, that is the psoas muscle. Now, these hyperechoic lines, these are your transverse processes. And transverse process, because the ultrasound is unable to travel further beyond the bone, that gives rise to this acoustic shadow. And hence it's all black down there. That's why this all is just black. And that's anything in between. If you see, that is your window. That's where you are seeing the psoas muscle. So these structures, these are your transverse processes. That you'll expect to see the yellow one. If it's slightly tilted, then you see this. This is your posterior dural complex. Now, Karmakar, one of the senior colleagues, he has described that, and they used this phantom. And what they did was this phantom, when they did in vitro, the kind of image what generated was something like this. So this was the transverse processes. This was in the phantom. In healthy volunteers, so these were the transverse processes, followed by acoustic shadow. Just next to it was the window. And they called it as a trident sign. Trident means trio. So if you're seeing three vertebrae or three transverse processes, the shadow, what it's causing, is like the spear, Lord Shiva's spear, trident. So they called it the trident sign. And in the cadavers, it was seen that this green mark was the transverse process of L3 and L4. Above that was the erector spinae muscle. Just underneath there was the psoas major. Now, what happens if we move from there? If you remember, when first initially we were there at the transverse process. Now we have moved slightly more inwards. So remember that structure. What was it? That was the articular process. So this is the kind of image which generates when you're on top of the articular process. So you see still the bony shadow. In between you're seeing a window, again a bony shadow, window, and again a bony shadow. So this window, what you're seeing there, that is something of our interest because we are able to see in between structures. Bone, 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 articular processes. And in books, if you read, so if you just have a very close look at this structure like this, it resembles very much similar to something like this. So people started calling it a camel hump when it looks like a camel hump. So this is called as a camel hump sign, but this is when you are at the level of the articular process. This is something just to remember that if you see something like that, you need to be somewhere more medial. This means if you're seeing such image, that means you are still a little bit lateral. Trying and attempting to do your epidural at any of this one or the previous one, you'll not achieve any success. So you need to be a little bit more medial to this. Let's see the next slide, what it shows. But remember that if they talk about the camel hump sign, means you're at the level of the articular process and you need to be more medial than that. So if we remember that we were at the transverse process, then we were at the articular process. Now we have come a little bit more medial. That will be the lamina. So all of a sudden now, this has become more horizontal rather than being more acute or hump-like. Now, This got given another name. There are lots of animals in there. And also another thing what they did was, the probe is tilted now slightly inwards. So it became parasagittal oblique laminar view. So this is the lamina, this is the lamina, this is the lamina. So this was done in the phantom, so hence we can't see the muscles. But when done in the volunteers, this was the lamina, this is the shadow, blackout dropout shadow. This is a window. So now we can see that the window is smaller than the shadow for reasons we discussed before. However, we are seeing some more structures down there. So this is a hyperechoic line again. Remember, connective tissues give hyperechoic shadow. This is another hyperechoic shadow. So that's a lamina again. And in between these two lamina is your interlaminar space, followed by another hyperechoic shadow, which should be the posterior dura mater complex. This is the structure what we are interested in. Now, if you have a good machine, you may see that this might be something like this. Now, what is this? That is the ligamentum flavum as labeled LF. And this one, the hypoechoic structure, because it carries, it's a potential space, that's your epidural space. And that is your posterior dura. So Karmakar has described that the dura appears more hyperechoic than ligamentum. But in the first paper by Crow, he thought that ligamentum appears more hyperechoic than the dura. However, when we see things with ultrasound, they both appear as one line, one hyperechoic shadow. And that is what is the posterior dura mater complex is. Then this is your hypoechoic fluid-filled structure, that is your spinal canal, and that is your anterior complex. Any questions so far? Now in this view, as described earlier, so this probe, which was initially kept vertical, now this is tilted slightly inward, so we are shining the light through the lamina to see inside of the spinal canal. These are all your lamina. I'm sorry for interrupting. I think there's this window. Can you get rid of this window, please? Okay, let's carry on then. So when we are flashing the light through the lamina and we are trying to see the spinal canal, these are the structures what we see. So first thing was, we are through the lamina, so that thing is represented here. If there was another vertebra on top of it, which is here, we are seeing another lamina. In between, we see this is the interlaminar space, another lamina, and that is the space. I'm sorry, this black line, I didn't want this to be there. So these yellow structures, what we are seeing, this yellow structure, that is the posterior dural complex. That is your anterior dural complex. In between these two green lines is your spinal canal. And if we correlate that to this picture down, so these are your lamina. This is in cadavers. So these are your laminas. That is your interlaminar space. That is your dural complex. And that is your epidural space. And just correlating it here, we've marked it here, but here as well it should be your anterior dura mater complex. Now next thing is, how do we identify the level? So we know what to expect and what to see, but how do we get to know which is L4, which is L5, or L4-5 interspace, or L5-S1? So we are still scanning in the parasagittal plane. So when we start from bottom, or from caudal to cranial, we see a white line, and that is sacrum. Here, that's the sacrum. And then all of a sudden, we see a dip. So that dip is your L5-S1 interspace. Then there's another line, that is your hyperechoic shadow of your L5. Then there's a dip. Then there's another hyperechoic line, and that's the lamina of your L4. So that's L4, L5 space. So what you need to do is you need to scan from caudal to cranial. Well, obviously, you have to make sure that how your probe is orientated. You need to know which side is which. So if you're seeing on the ultrasound machine, Atul, is it possible for you to sit there?
Yeah. Okay. Yeah. Thank you.
I think this will be easier if we show it to you in live as well. Then you will be able to correlate it slightly better.
So we need to move on to the screen.
In the meantime, so all the red lines, these are your hyperechoic structures, and those are your laminas. In between interspace, L4-5, and that's your posterior complex, and that's the structure we are interested in. Now, having identified the space, now we need to see how would it look like, and we would need to change our view or your axis from being parasagittal to transverse. Now, when we rotate our probe from parasagittal axis to transverse, there are only two things what can happen. The first one is that either we could be at the level of the spinous process, or we could be in between the spinous process and in the intervertebral space. So if you're at the level of the spinous process, this is somewhat kind of a picture what you'd see. So you'll see one kind of hyperechoic dot, that's the spinous process. Now, because ultrasound wouldn't travel further down, you'll see a dropout shadow, and you'll see this hat-like, inverted V-like shadow. So this is all acoustic shadow of the transverse process. And then you see these horizontal lines, which are the lamina. Now, if we just move our probe slightly either upwards or downwards, then we would possibly be at the level of the interspace. And this is the kind of image which we started with initially. This is the kind of image which will be generated. So now we are in between these two spinous processes or interspinous space. So what we see is the interspinous ligaments. So this is the kind of picture what we'll be seeing. So there is some acoustic window. These are the ligaments, and now we are seeing some hyperechoic structures. So these hyperechoic structures, as described below, are the articular processes. And there's another structure, another line, which is just underneath there. That's the transverse process. And if you visualize the vertebra back again in your mind, you'll know it that the articular process and lamina were higher above than your transverse process. So that exactly what the representation is of. Now, Atul has got it there. So he's in between the spinous process, or in the interspinous space. And the structures, what we are seeing, those are the articular processes. So the top two lines, again, these are the articular processes. And these are your transverse process. This is what the structure we are most interested in. That is your posterior dura mater complex. And that's your anterior dura mater complex. And the hypoechoic shadow, what we are seeing in between the two yellow lines, that's your spinal canal.
This is Info Media Prime Slot Network, and you're watching Prime. Your voice, your channel.